Hello, good evening. I hope everyone's with us tonight. We're coming at you from our new studio. It's very fancy. You guys can't see it, but I promise you it's very, very nice. So I'm glad everybody's here. We're going to be talking about hammertoes, which is a very common thing we see and treat in our clinics. So I wanted to go over some of the causes, treatments, and everything in between about the hot topic of hammertoes tonight. So let's see. So just a quick background on those who know me, those who don't. I graduated from Florida State University as my undergrad. I went to Podiatry School of Medicine at Barry University down in South Florida. Some more background on podiatry. There are about 10,700 practicing doctors of podiatric medicine in the United States. These are physicians that specialize primarily in conditions affecting the foot and ankle. Interesting fact, about 75% of Americans will experience some degree of issues with their feet in their lifetime. So some more cool facts about feet. Average person takes about 8,000 to 10,000 steps a day. All of this added up is about 110,000 miles in a lifetime, which is 4 times around the globe. So there's a lot going on down there, a lot of weight that's being pressed upon those small toes we're going to be talking about tonight. So US population annually, about 19% will experience about 2 foot problems in a year. 5% have an infection of some sort. 5% will have some sort of ingrown nails, and 5% will have calluses. So all in all, basically what we're trying to say is that there's quite a bit going on in our foot. So some interesting facts about foot anatomy. The foot contains about 28 bones, 33 joints, 107 ligaments, and 19 muscles. 56 bones in your feet make up about 1/4 of all the bones in the human body, which is pretty amazing. Okay. So this brings us to our topic for tonight, which is that of hammertoe deformities and correction. So just to break down what we're going to be speaking about, we're going to be first talking and diving into some general toe anatomy so that we can get acquainted with what exactly is happening. We're going to go over the classification of hammertoes. Hammertoes have varying classifications depending on the actual deformity that's occurring. We're going to talk about the causes, the etiology of these conditions, and then what everybody wants to know about treatment, both conservative and surgical treatments available for the treatment of hammertoes. All right, so let's dive into it. So I'm hoping all of you can see this on your screen, and this is toe anatomy. So simply, toes are comprised essentially of 2 joints, of which the third is what connects the toe to the foot. They are for acronyms, DIPJ, PIPJ, and MPJ. And those are in order from the very tip of the toe all the way to the base of the toe. There's 2 sets of muscle groups that control the toe. And this is really the working component of what we're going to be talking tonight. So we have what's called intrinsic muscle groups. And these are the muscles that are primarily located within the foot itself. These are smaller muscles that have very intricate attachments to the toe. And the function of these muscles is actually to stabilize and control the function of larger muscles that come from our leg that connect into the toes, which we call extrinsic muscles. So the way that I always view hammertoes in my head is that there's this constant fight between the smaller muscles and the bigger muscles. And that imbalance essentially is what causes these hammertoe deformities to occur. So some more toe anatomy about these intricate attachments. Here we see a side view of what we like to describe as the extensor apparatus. The extensor apparatus is a soft tissue structure in which the primary abundance of all of the ligaments, tendons pass through or attach into and control the positioning, flexion, and extension of the toe. So as you can see here in the diagram, we see the 3 joints, again, starting from the very tip. We've got the DIPJ, followed by the PIPJ, and then at the base, the MPJ. So we're going to be using these terms interchangeably or quite a bit this evening. So if you follow with me, as you can see, the extensor hood, the extrinsic and intrinsic musculature passes through this structure. So hammer-toe definition. So what I often see in my office is that we'll very routinely use the term hammer-toe to describe any condition afflicting the toes. But in fact, it is a term that's often used interchangeably to describe a variety of different deformities affecting the toes. Generally, it refers to an imbalance which occurs by what we just talked about, that constant fight between the small and large tendons or muscles that insert into the toes themselves. Okay. So we often call them hammer toes, but we're going to dive into the actual classification of hammer toes and how each one is kind of different. So here on the right, what you see is just a very typical foot that shows two varying types of hammer toes, and we're going to dive deeper into that. So classification, after you kind of spend some time with it, is relatively simple. We generally describe any hammer toe as either rigid or flexible, and we'll dive further into that. Beyond that, we have three different classifications for hammer toes. We have a classic hammer toe, which is the middle picture here on the diagram on the right. We've got a claw toe, which is the top picture. And then we have a mallet toe, which is the very bottom. So what this classification refers to is exactly where the bend is occurring on the joint itself. And we'll explain that a little bit further. And then the rigid and flexible component can be applied to any three of these classifications. And simply it just describes, are we able to push the toe back into a straight position or not? So here dives a little bit deeper into the flexible versus rigid hammer toes. So flexible hammer toes are usually what we see in the very beginning of the onset of the deformity. At this point, what we're seeing is that there is an imbalance, there is a malposition of the toe, and the toe is starting to bend at any one of those three joints that we've talked about. The difference here is that if we manually press down on the toe and pull it outward, we can often get it to straighten out. But as soon as we let go of the toe returns back to a deformed position. A rigid hammer toe occurs when that imbalance of intrinsic, extrinsic musculature has been ongoing for so long that the joints and the soft tissues have adapted and have now become permanently positioned in that way. We often hear when our mothers would tell us not to make these faces because your face is going to stay in that position. In this case, it is true as it regards to rigid hammer toes. So let's dive into the first classification of hammer toe, which is the classic hammer toe. So the classic hammer toe is a contracture or a bend at the proximal interphalangeal joint, or PIPJ, usually in the second toe, but it sometimes does occur in the third toe. It is extended at the base of the toe, which is the MTP. So the joint is flexed in the very middle, the very tip of the toe is straight, and it usually causes a bump to develop at the very top of the toe, as we see on the bottom picture, which is a depiction of what a classic hammer toe looks like. Here we have an example of a mallet toe. So a mallet toe occurs when the only joint that's flexed is that at the very, very tip of the toe. So you see that at the very end of the toe, that toe is turned downward, and it essentially looks like a mallet or a hammer, right? Often with this condition, what we'll see is that patients will develop some callus formation or painful lesion at the very tip of the toe, because as they walk, that's the first thing that is hitting the ground. So you get these lesions at the very tip of the toe that can become painful, and that's a sign that what you have is a mallet toe. On the right, you see here a picture showing what a mallet toe looks like. Mallet toe is a deformity that often occurs due to a secondary medical condition. Usually we see this in patients that are diabetic or neuropathic. Again, in these patients, the small muscles, the intrinsic muscles, start to lose their ability to control the larger tendons due to neuropathy or loss of sensation. And lastly, we have the Clato. As you can see on the right, it really does look like a claw, right? Here we have flexion at both the joints in the toe, the PIPJ and the DIPJ. So it creates this curved appearance of the toe that goes all the way around. It's like a little semicircle. And this is a true imbalance between the extrinsic and intrinsic muscles. And again, this is another condition in which diabetes and other neurological conditions can result in this type of deformity. So now we get into the causes. We've talked a little bit about certain diseases that can lead to hammertoes, like diabetes and neuropathy. Oftentimes, the primary cause of hammertoes is hereditary. Certain foot types, either whether it be a flat foot or a cavus foot or a high arched foot, can result in an imbalance that manifests itself at the toes. The other component is trauma. So an injury in which you, and we've all been there, stubbed our toe in the middle of the night, jammed it, broken our toes. This can lead to the development of arthritis in the joint itself, which can result in an imbalance of those ligaments on the toe. And then we got to the true abnormal balance of the toe muscles that we've been talking about all evening. Certain shoes, and there is some truth to this, can lead to the development of hammertoes. Like we've talked about, long-term adaptation at these joints can occur. So if you have gone years wearing very narrow toe box shoes or high heels, and I'm sorry to say it, ladies, but it's true, you have a tendency or a higher risk to develop these hammertoes. So these are risk factors. So who is more likely to develop hammertoe deformities? So of course, and I hate to be the ageist, but yes, age does play a part. Wear and tear, natural wear and tear can predispose someone to the development of hammertoes. Women, like we've talked about, due to footwear, like high heels, are more prone to developing hammertoes as well due to that soft tissue and joint adaptation. One that is often not spoken about is toe length. So there are many types of foot structures in which the second toe is longer, and that can result in the development of a mallet toe because the very tip of the toe is trying to reach the same length as all the surrounding toe. Biomechanics. So like we talked about, either a flat foot or a cavus foot, this imbalance can result in the development of hammertoes. One thing that can also lead to the development of a hammertoe is that of a bunion deformity. So patients that have a bunion deformity can develop a secondary hammertoe deformity because that big toe is now encroaching on the space of the toe right next to it. And that imbalance over time with soft tissue adaptation can result in a hammertoe development. And then again, just to really hit it home, certain diseases. So arthritis, diabetes, neuropathy, all of these conditions play a significant role in the development of this disease because it does impact the balance between intrinsic and extrinsic muscles. So treatment. Here on the right is just a very quirky picture of an actual patient of mine who had some severe hammertoes. This is not the norm. I just like to put these pictures in there to kind of drive the picture home. But here we've got conservative versus surgical treatment options. Okay? And this is often determined by the extent of the deformity. And like we talked about previously, has a lot to do with either the deformity being rigid versus flexible. And of course, failure of conservative treatment often can lead to a more formal discussion regarding surgical repair or surgical treatment of these hammertoes. So here we have conservative treatment. And this is really where I start off with all of my patients that come in initially with a hammertoe. We often talk about padding. And there's many different types of padding available to us to treat the certain type of hammer toe that a patient presents with. So on the right, you'll see 4 different pictures depicting 4 different things that we use in the office or recommend to patients in the office to treat a hammer toe, each of which has a more specific use, and we'll dive into that. The first is the one you see on the first top left-hand corner, and that's something called a silicone toe sleeve. Those of my patients that have been to my office, they've often heard me talk and preach about these silicone toe sleeves. They are a little sleeve that goes around the toe, and it actually protects the toe from tip to end. This is often a great conservative measure, often employed for the treatment of either a classic hammer toe or a Clato, primarily because what this is doing is it's providing a protective barrier between the top of the toe that could be rigid and rubbing up against the top of a shoe. So by doing this, not only are you somewhat holding that toe straighter because it is in a sleeve, it's also acting as a very cushioned protective barrier for the toe itself. The second is a boot and splint, which you'll actually find on the right top hand corner of your screen. A boot and splint is often used to treat deformities like classic hammer toes and claw toes, because what it does, it has essentially a fabric toe ring that goes around the toe, and it pulls that toe down. Now, it makes sense that this type of splinting primarily works best for hammer toes that are flexible, because that hammer toe can lay flat as it's being held down in place by the toe ring attached to the pad on the bottom of the foot. And then we've got corn pads. Corn pads that can often be used for any corn on the foot, but I often use them for the treatment of mallet toes, because in this case, a mallet toe will develop a very painful lesion at either the tip or the top of the very end of the toe. By putting this little protective pad over that area, it really relieves pressure when a patient is inside a closed-toed shoe. And then lastly, we've got toe spacers, which is the very bottom right-hand corner. Toe spacers are great in hammer toe deformities in which you've got rubbing between adjacent toes. This separates the toes and reduces that friction, which can often lead to pain. So some more conservative options that we always employ prior to having any formal surgical discussion. So changes in shoe wear. So of course, I'm going to be the bad guy and tell the patient, maybe high-heeled shoes need to be kept to a minimum, or we need to stay away from those very fancy Italian shoes that my gentleman will wear to the office, because these will often lead to the development of hammer toes. The other option we have is that of orthotic devices. And this really hones in on the underlying cause of some of these deformities, like a cavus foot or a high arched foot or a flat foot. By using an orthotic device, what we're doing is we're correcting the actual underlying cause of the imbalance causing the hammer toe, which can lead to a delayed progression in the deformity, or it can alleviate the deformity actually present. Other options for the treatment of hammer toes, which are less often used, is that of corticosteroid injections. These are often used to treat some of these painful joints. My concern with cortisone injections in the treatment of hammer toes is that, as we know, it is a temporary fix. It will provide a certain degree of relief for several months in the best cases, but over time can actually wear down the very, very small joints in the toes. So it has to be used judiciously. So now we dive into the surgical management of hammer toes. I like to divide the surgical treatment of hammer toes into 2 categories: soft tissue procedures versus osseous procedures. The common thread in our conversation this evening has been that imbalance between the intrinsic and extrinsic muscles. The criteria that we use to determine whether a patient will do well with either a soft tissue or a bone procedure or osseous procedure is whether a toe is, or a hammer toe deformity is rigid or flexible, and we'll explain that a little bit further. So first, let's dive into soft tissue procedures. So soft tissue procedures are often procedures that are actually used in conjunction with other more extensive bone procedures or osseous procedures, or they can be used independently in the treatment of more flexible deformities in which the hammer toe can actually be laid flat manually. The first procedure we talk about is a tenotomy, also called a flexor tenotomy in most cases. And this is actually depicted on the very bottom hand side of your screen, labeled B. So this is used to treat the recurrence of ulcerations caused by Malatos. And this is often something I use for a lot of my diabetic patients that develop these Malatos as a result of neuropathy and get these small wounds at the tips of their toes. Soft tissue procedures alone or independently, don't, in my opinion, result in the best cosmetic appearance of toe deformities, but are incredibly useful in patients in which what we're really trying to achieve is offloading certain wounds, especially at the tips of toes. The other soft tissue procedure that we often use in the office is something called a capsulotomy. A capsulotomy is a procedure done on the top of the foot in which the capsule is released and it allows the toe to lay down, often used in the treatment of Clatos. Now we get into a more specialized treatment in a condition that is actually very, very common, both in flat-footed patients as well as patients with a high arched foot. As many of you have seen and often have, we have this fifth toe that tends to turn inward and bend at the same time. So we call this an adductovarus deformity of the fifth toe. And this is unique to the fifth toe and doesn't often happen in either toes 4, 3, or 2. So like we've previously described, this is a condition in which the fifth toe actually tends to bend in towards the other toes right next to it. Often what I tell patients is you will put your foot down, you can look down at your foot and you can't even see the top of your toenail on the fifth toe because it's bent in so much. So in this condition, and this is a soft tissue procedure, we do what's called a derotational arthroplasty. So in this procedure, what we do is we take a wedge of skin off of the very top of the toe, we excise this wedge of skin, and when we bring those two edges of skin together, the way that the closure is performed, it actually derotates the toe into a corrected position. So we get that toenail, which was before hidden underneath the fourth toe, back up to the surface where we can see it. And this is often something we do for hammer toes, specifically of the fifth toe. So now we start to get into more osseous procedures. And I like to always mention that these more osseous or bone procedures often do include some soft tissue procedures with them. So the first osseous or bone procedure that we talk about is something called an arthrodesis, which is the mainstay treatment for a variety of different hammer toe conditions because it is very generally adaptable to a variety of deformity types. So this procedure is done it's performed by fusing the proximal interphalangeal joint, which is the joint in the very middle of the toe. The joint itself, as you can see in the bottom right-hand corner, is resected. And often we use some sort of hardware that is placed in between that fusion site or soon to be fusion site that holds the toe in place as it heals together. This is often used again for the treatment of non-reducible conditions, which brings us to the point as to osseous or bone procedures are often more utilized for non-reducible conditions because purely soft tissue procedures are not going to achieve the correction necessary. One thing that we do need to mention, oftentimes the hardware that's used to hold the two ends of the bone together remain within the toe itself, as you can see in the top right-hand corner. So we leave this hardware in place. It really causes no issues. It is very rarely ever have to be removed, and it stays in. Another option, which you can see in the bottom right-hand corner, is utilizing a pin or a K-wire, in which we use this wire. It actually sticks out the end of the toe, but it is removed in the office after about 3 to 4 weeks. So now we dive into the post-operative protocol. So often hammer-toe procedures are performed, again, in conjunction with other procedures, making post-operative course variable. So as we've talked about previously, we often correct hammer toes at the same time as we're correcting other pathologies of the foot, like bunions or other conditions. So that will play into the post-operative course. Independently, hammer toes that are corrected in and of themselves require a post-operative period of partial weight bearing that can remain for about 3 to 4 weeks, in which the patient is wearing a special shoe and they're essentially just walking on their heel. We often transition these patients into a regular tennis shoe or well-padded shoe at about weeks 4 to 5 after surgery. One thing that is often asked about is the swelling that occurs after toe surgery. And it is something that we do see all the time with toe surgery. Toes, as you can imagine, are the furthest extremity from the heart. So they're very prone to the development of swelling, especially after surgery. Toes can remain swollen after surgery for about 6 months, up to a year after the procedure, but they do ultimately go back to a regular size. So in summary, hammer toe deformities. The term hammer toe is often used interchangeably for most deformities of the toes. Conservative treatment can be effective in early stages of the deformity or those deformities that are reducible. Surgery is indicated if pain is constant despite attempted conservative treatment or the deformity is rigid. Soft tissue procedures are used for more mild deformities, and the postoperative course of a hammer toe correction does vary depending on if any other procedures are performed at that time. So that concludes our presentation this evening on hammer toes. I know it was a lot to take in a short amount of time. I certainly do appreciate your attention, and we're going to be doing some questions. I was just told we're going to be doing some questions. Okay. So this actually does depend on your foot type and who you ask. So in my opinion, the two most common deformities is going to be of the second and fifth. And I think it's a pretty good competition between the two. So the second toe is the most afflicted by all 3 different hammer toes, the ones we've talked about, the classic, the mallet, and the claw. The fifth toe we see across the board on a variety of different foot types. And that's that deformity in which the toe is turned inward. So if I had to put my money on one of them, I would say across the board, most patients will develop a hammer toe of their second toe. So that's a great question. Usually, as a general rule, foot surgery should be done 1 foot at a time. In my opinion, it certainly does specialize the care to one deformity at a time. However, in milder conditions in which we're only independently treating a hammer toe and the patient has that deformity on both feet, we can consider treating both at the same time. Now, there are other factors that play into this: patient's age, patient's ambulatory status. Are they able to be in a limited capacity on both feet after surgery safely? But as a general rule, I will say that you want to do 1 foot at a time. So if we're talking about runners, and in that regard, any type of high impact athlete or weekend warrior, whatever you'd like to call it, I often tell patients you're not going to be engaging in anything that's going to be an explosive type of movement, such as running, until about 2 to 3 months after surgery. And that a lot of it that has to do with some degree of discomfort that can be developed throughout that activity. If everything postoperatively looks great, the incision site looks excellent, x-rays look excellent, patient is doing well, and we're ahead of schedule, sort of speak, then what I will tell them is to gradually return back to their usual activity. And for that, I'll tell them to use the rule of quarters. So the first week, you'll start at 25% of what you were doing originally. You'll increase that the second week to 50, third week at 75, and by the end of the month, you're back to 100%. And that's kind of my general rule for most foot surgery after you've been cleared. So incisions on hammer toes, if we're doing bony procedures, will have sutures in place or stitches in place for about 2 weeks after surgery. At the 2-week mark, we often remove the sutures, and at that point, the incision site is relatively completely healed over. We still protect it for several days after that, but what every patient is looking for after surgery is you're able to get your foot wet at that point, or take a regular shower without having to keep your foot dry, right? As far as a scar, it often does leave a scar. The scar is very, very small, and it's often just localized over the very top of the toe. So it's not a very visible scar that we can really see. I love this question. And this really does apply across most foot conditions. And we talk about splints and different things that can hold a toe into a corrected position. And we say, well, you know, if we wear this for long enough, if soft tissue adaptation is truly as we talk about, why shouldn't it correct it? The problem is that the actual underlying cause of the deformity is still present. So the moment you remove this splint or toe crest, that deformity is going to return. So what I tell patients is that wearing these different splints or pads will delay the progression of the deformity. However, it's not going to correct it long term. Definitely, and it's certainly encouraged. Very rarely would we want to stage a hammer toe and a bunion correction. We do them at the same time. Now, when you add on different procedures to one stage of surgery, it may increase the postoperative course a little bit more. Usually, the addition of hammer toe corrections to a bunion correction does not add much more time to the postoperative healing, but to answer your question, yes, we do them both at the same time. If you start counting toes individually, I would say that definitely in the thousands. I haven't sat down to count, but it's definitely in the thousands if you start to think in doing several hammer toes per foot or over the course of the past 6 years. I'm sure the math is up there. So yes, Lapiplasty, and this is Jacksonville proud. It's a company here in Jacksonville that has developed a very nice system to do a type of bunion surgery that has been utilized for many decades. However, what this company has done is that they have developed certain type of jig system and device that makes the procedure very reproducible and also allows for a more precise correction of the deformity. But yes, I do perform Lapiplasty procedures for the treatment of a certain type of bunion. Correct, yes.